Okay. All right. Welcome to another study stream. Today we have a shit ton of pathoma to get through. Because we're extremely behind. And it's snowing outside and I really can't focus. And I keep getting distracted and I don't have the option of going outside to study to keep myself motivated, so I must keep myself accountable one way or another. So, we're going to watch Pathoma, just annotate notes, and honestly just get through all of it. I wanted to make flashcards, but I might just skip that part because I genuinely just need to get through the content, and then probably we'll do USMLE RX. Yeah, I don't know. It's a toughie. Okay.
The next of the normal cytic anemias are those with predominantly intravascular hemolysis, and the first of them that we want to cover is paroxysmal nocturnal hemoglobinuria. I actually prefer to explain this in my own words, and then I'll walk you through the slides. So let's just take a blank screen for a second and remind ourselves of a couple points. First of all, the red blood cells, they live in a very dangerous environment. They live right next to complement. Their neighbors are deadly. And so the red blood cell needs to be protected against complement. And in fact, this doesn't apply to the red blood cell only. It also applies to the platelets and the white cells as well. And so the red blood cells, in order to protect themselves against being destroyed by their neighbor, i.e. complement, they actually have a molecule on their surface, and that molecule on their surface is called DAF, decay accelerating factor. They also have another molecule on their surface, which is called MERL, membrane inhibitor of reactive lysis. And so these two molecules, what they do is, were complement to get activated, if complement were to try to come anywhere near the red blood cell, these two molecules would inactivate the complement. DAF stands for decay accelerating factor, and it accelerates the decay of C3 convertase, for example. Now, it's important to then note that DAF and MERL are both connected to the red blood cell membrane by an anchoring protein called GPI. So this is GPI. And this anchoring protein is essential because it's what allows DAF and MERL to be expressed on the surface of the red blood cell. In paroxysmal nocturnal hemoglobinuria, the problem is the patients get an acquired. Note that it's an acquired. It's not inherited. It occurs later in life. It's an acquired defect in the myeloid stem cell. And because there is a defect in the myeloid stem cell, GPI will not be present in all cells derived from the myeloid lineage. So, for example, the platelets will not have GPI, the red blood cells will not have GPI, and the white blood cells, in particular the granulocytes, will not have GPI. And because there is no GPI, there's going to be no DAF. And if there's no DAF, and there is no MERL, for example, then the cells will be susceptible to destruction by complement. And that's the problem in paroxysmal nocturnal hemoglobinuria, and that is that the cells are susceptible to complement destruction. Now, we're not done there. We've got to go one more step further and explain the name, paroxysmal nocturnal hemoglobinuria. In order to understand this, you have to go back and remind yourselves from physiology, when we sleep at night, we actually breathe shallow. And when our breathing becomes shallow, we retain carbon dioxide. And when we retain carbon dioxide, that then gives us a respiratory acidosis. Now, acidosis has the ability to activate complement. So at night, we are activating a little bit of complement. Of course, patients who have normal red blood cells and normal white blood cells and normal platelets would have no problem with this activation. They could simply protect themselves against that activation. However, in patients who have an absent GPI and don't have these protective molecules, they will be susceptible to complement-mediated damage in particular, or classically when they're sleeping at night. And so that's why it's called paroxysmal nocturnal hemoglobinuria, because on some nights, i.e. paroxysmal, when the patients are sleeping, they actually get lysis of their red cells and platelets and granulocytes, but in particular their red cells, which then results in the hemoglobinuria. When they wake up in the morning, they've got very dark urine. So that's the summary. Now let me walk you through what the text says. Paroxysmal nocturnal hemoglobinuria is an acquired defect, that's important, in the myeloid stem cell, that's important, results in absent GPI. This then renders the cells susceptible to complement because there is no DAF and there is no MERL present on their cell surface. In particular, the patients get intravascular hemolysis that occurs at night. Intravascular because the complement destroys the red blood cell within the blood vessel. At night because that's when complement gets activated. Why does it get activated at night? Because there's shallow breathing resulting in a respiratory acidosis, which then results in activation of complement. And of course, the red blood cells, the granulocytes, and the platelets are all lysed because each of these cells are lacking the GPI linker molecule. This presents with intravascular hemolysis, so the patients present with hemoglobinemia. If you were to look in their blood, you would see hemoglobin. Some of that hemoglobin will leak out into the urine, giving you hemoglobinuria. And also, some of the hemoglobin in the urine will be taken up by the tubular cells in the kidney, and as it piles up in the tubular cells of the kidney, it'll pile up as hemosiderin. Now, eventually, the tubular cells of the kidney will be sloughed off as they turn over, and that'll give us hemosidenuria. But that will be seen days after the hemolysis, so it won't be seen with the acute episode, but it might be useful if you're suspecting hemolysis and you want to check for it days after the event occurred. One way by which we can screen for this disease is to introduce sucrose into the patient's serum. When we introduce sucrose, that activates complement, and that could then destroy the red blood cells in a screening test. A confirmatory test would be to acidify the serum. If you acidify the serum, you would activate complement, which would then also confirm the disease. Nowadays, the more recent test, and the test that's more often used in laboratories today, is to look for a lack of CD55 on the surface of the red blood cells. If you have red blood cells and you want to see whether they have CD55, an important thing about CD55 is that it uses GPI as a linker molecule. So if there is a population of red cells in the patient that lack CD55, that would be a way by which you could prove that the patient has paroxysmal nocturnal hemoglobinuria. And CD55 really is DAF, so that makes sense because DAF was the whole molecule that we started this discussion with. The main cause of death in patients is thrombosis. The idea here is that the complement's going to destroy the red cells, the platelets, and the granulocytes. And so when it destroys the platelets, the fragments of the destroyed platelets can actually go into the circulation, and that can activate the coagulation cascade, resulting in thrombosis. And so that's the main cause of death. And so examiners love to go after it because it really tests you on two principles. One, you need to remember that the platelets are also lacking GPI. And two, that's the major cause of death in these patients, thrombosis of hepatic vein or portal vein or cerebral veins, for example. Complications of the disease include iron deficiency anemia. Why would they get iron deficiency anemia? The answer is these patients are losing iron in their urine. As they're losing hemoglobin, they're actually losing iron. And so they can develop an iron deficiency anemia. In addition, 10% of the patients can develop AML. Now remember that I told you that this disease is a mutation in the myeloid stem cell. So imagine if there's one mutation in the myeloid stem cell, it's not going to be hard to develop another mutation in that cell, and eventually that could result in AML. And 10% of the patients do develop AML, and that is a high-yield association as well. The second of the predominantly intravascular hemolysis disorders is G6PD deficiency. G6PD deficiency, again, requires a little bit of biochemistry to understand, so what I prefer to do is explain it in my own way, and then I'll walk you through the slides. When you think about G6PD deficiency, what you need to understand is that the red blood cells, they live in an environment of oxidative stress. The red blood cells, they live in an environment of oxidative stress. To protect themselves against that oxidative stress, for example, just by the fact that they carry oxygen, by the fact that there's going to be inflammation in the body, etc., those are all oxidative stresses. To protect themselves against oxidative stress, they use a special molecule called glutathione. So glutathione is very important to protect against oxidative stress. For example, H2O2, which is one of the major sources of oxidative stress, can be taken by glutathione, and it can be reduced such that glutathione will reduce it and then become oxidize itself, resulting in GSSG. Now, when glutathione gets oxidized and takes the hit to protect the cell against H2O2, that's great because it protects it against an oxidative stress. However, in order to continue to protect the cell against oxidative stress, it needs to be reduced back into glutathione. The molecule that's necessary to do this is NADPH. And NADPH is produced via G6PD, glucose-6-phosphate dehydrogenase. So one of the byproducts of glucose-6-phosphate dehydrogenase is NADPH. No glucose-6-phosphate dehydrogenase, i.e. glucose-6-phosphate dehydrogenase deficiency, means no NADPH. No NADPH means no ability to regenerate reduced glutathione. No ability to regenerate reduced glutathione means that there's going to be increased oxidative damage to the red blood cells. So that is G6PD deficiency in a nutshell. Now let's walk through the slides. So in G6PD deficiency, it's an X-linked recessive disorder with a reduced half-life. That's important, reduced half-life. I'll highlight that in a moment. This renders the cells susceptible to oxidative stress. Now, G6PD has two major variants. There's an African variant where there's a mildly reduced half-life, and there's a Mediterranean variant where there's a markedly reduced half-life. The high gene frequency in both of these populations is because it has a protective role against falciparum malaria. Let me go back and just remind you that when we talk about the two variants, the two variants can result in somewhat different clinical severity of disease. So remember that in the African variant, there is a mildly reduced half-life of G6PD. So let's just draw a few cells. Let's pretend this is 30 days old, 60 days old, 90 days old, and 120 days old. So 30, 60, 90, and 120. And let's draw the same thing here. 30, 60, 90, and 120. 30, 60, 90, and 120. Now, in the mild form, well, why don't we take a step back? In the normal patient, G6PD's half-life is such that it lasts the entire life of the red blood cell, so that a normal red blood cell, no matter how old it is, has sufficient G6PD. In the mildly reduced half-life, the G6PD is not present in cells that are older because obviously they've lived longer and the half-life of the enzyme was not able to allow the enzyme to be present for a long period of time. So in a mildly reduced half-life, maybe only the older cells don't have G6PD. So if there's an oxidative stress, then what will happen is only the cells that are older will be destroyed. And that's the African variant. In the Mediterranean variant, where there's a markedly reduced half-life, the G6PD is removed much earlier. And so, for example, when there's an oxidative stress, all these cells at greater than the age of 30 days, for example, will die. And that's because there is a markedly reduced half-life of G6PD. Now, what are the oxidative stresses to be aware of? Well, the causes of oxidative stress include infections, drugs, and fava beans. And fava beans are classic, especially in the Mediterranean variant, because they are particularly consumed in the Mediterranean regions. When the oxidative stress hits the cell, then that causes hemoglobin to precipitate as a Heinz body. The precipitated hemoglobin is then removed by the splenic macrophages, resulting in bite cells. And that then results in intravascular hemolysis. Now, there may be some extravascular hemolysis in that the macrophages may sometimes consume the entire cell rather than just creating a bite. But the predominant hemolysis is intravascular. Here's an example of a bite cell. The splenic macrophage has taken a bite out of this cell, and the idea here is that if there is a big precipitate of hemoglobin, the splenic macrophage will simply remove that, and when it removes it, it's going to end up removing a big piece of the cell with it. Now, these patients are then going to get intravascular hemolysis. This presents with hemoglobinuria, so they get hemoglobin in the urine because of intravascular hemolysis, and classically get back pain because the hemoglobin is nephrotoxic, and so that results in the back pain that's classically seen. This occurs hours after exposure to an oxidative stress. If you want to try to see the precipitated hemoglobin, you won't be able to see it in the normal blood smear. Instead, a special preparation called the Heinz preparation must be made, and this will be a screen for the disease. The Heinz preparation will then highlight the precipitated hemoglobin. And so here's an example of a Heinz prep showing the aggregate of hemoglobin. Important to note that if you want to confirm the disease, you must do enzymatic studies. But you will not do the enzymatic studies until after the disease has resolved, i.e. after the acute episode. If you did the enzymatic studies at the time that there was hemolysis, all the cells that are lacking the enzyme will be dead. And when you test the remaining red cells, those are the ones that actually have the enzyme because they had a half-life sufficient within that red blood cell. So we don't do the enzyme test until the patient has actually resolved the acute hemolytic episode. And that's an important take-home point as well. Another important cause of hemolysis is immune hemolytic anemia. Now, immune hemolytic anemia is antibody-mediated.
Wait, I wasn't fucking paying attention like the last 5 minutes. Oxidative stress precipitates hemoglobin as Heinz bodies, causes of oxidative stress. Infections. Drugs. Fava beans. Heinz bodies are removed from RBCs by splenic macrophages. Bite cells. Oh yeah. I kind of remember this. Predominantly intravascular hemolysis. Presents with hemoglobinuria and back pain. Back pain. Okay. Enzyme studies confirmed deficiency. Okay.
Destruction of the red blood cells, and it can be due to IgG or IgM. If it's due to IgG, that's called IgG-mediated disease, and that usually is extravascular hemolysis. The idea here is that the IgG will bind the red blood cell. It's also called a warm agglutinin because it binds the red blood cell in the relatively warm temperature of the central body. When the RBC is coated with the IgG, the membrane and IgG will actually be eaten up by the splenic macrophages, and that will slowly remove membrane from the cell. And the slow loss of membrane from the cell will result in spherocytes. It's very similar to hereditary spherocytosis. Again, the idea is that if this is the red blood cell, and you slowly pick off a little bit of membrane using an antibody, then as you take away more and more membrane, you're going to lose excess membrane, and these cells will convert to spherocytes. So on blood smear, you would see the same thing that you would see in hereditary spherocytosis. This IgG-mediated disease is associated with lupus. And remember that in lupus, you can get antibodies against red cells, antibodies against platelets, or antibodies against white cells. It's also associated with CLL. In chronic lymphocytic leukemia, one of the complications is that the patients can actually develop an autoimmune hemolytic anemia, usually IgG, and it's also associated with certain drugs. Now, when it's associated with drugs, there's a couple ways by which those antibodies can actually cause destruction. One way is that the drug can actually attach to the red blood cell membrane, and that occurs, for example, with penicillin, and then the antibody will bind the drug membrane complex, and that will then allow for removal of pieces of membrane. Another way is that the antibody is that the drug can actually induce production of autoantibodies itself, i.e. the drug causes the production of autoantibodies. An example of that would be methyl dopa, and those antibodies then bind antigens that are present already on the red blood cell. So that's a couple mechanisms of how drugs might result in autoimmune hemolytic anemia. The treatment is going to be to remove the drug if it's indeed caused by a drug, steroids to slow down the production of the antibody, IVIG, this is IV immunoglobulin, and the idea here is that if you give IV immunoglobulin, the splenic macrophages will eat the IV immunoglobulin instead of eating the immunoglobulin attached to the red blood cells. And so IVIG is like throwing a stick at a dog so that it runs the other way. You throw a stick at the spleen so it starts eating the IVIG instead of the red blood cells. It buys you some time. And then splenectomy could be performed because there would be two benefits. Number one, it removes the source of antibody. And number two, it removes the source of destruction because it's predominantly the spleen that's eating those antibody-bound red blood cells. And so that's a little bit about treatment. Of course, splenectomy is the last resort. IgM-mediated disease usually involves intravascular hemolysis, and the idea here is that IgM binds RBCs, usually in the colder temperature of the extremities, for example, the fingers and the toes. It then fixes complement, and when it fixes complement, that results in formation of a membrane attack complex, which then results in an intravascular hemolysis. Now, this is associated with two very high-yield concepts. Number one, Mycoplasma pneumoniae. Patients with Mycoplasma pneumoniae can subsequently develop an IgM-mediated intravascular hemolysis, which would be autoimmune, and also it can be seen with infectious mononucleosis. So those are a couple of high-yield associations for IgM-mediated autoimmune destruction of red blood cells. The Coombs test is what is used to diagnose immune hemolytic anemia. There are two types of Coombs test. There's a direct and an indirect. The idea in the direct Coombs test is that you're asking the question. Remember, whenever you do a test, you're asking a question. And so what's the question in this test? The question is, do I have red blood cells that are already bound by IgG? So you've got these red blood cells, and they're already bound by IgG, and you're asking the question, are these present? So what you do is you introduce another antibody against IgG, and if this exists, then that will cause agglutination. It'll cause the red cells to pile up and precipitate out. So that's the direct Coombs test. You take anti-IgG, you add it to the patient's RBCs, you assume, or you're asking the question, are the RBCs already coated with IgG? And if they are, agglutination will occur. This is the most important test for immune hemolytic anemia. The indirect Coombs test asks a different question. It asks the question, does the patient have antibodies in their serum? So now what you're doing is you're taking RBCs from, these are test RBCs, and you're putting in the patient's serum and asking the question, are there these antibodies in the serum? If they are, they'll bind the RBCs, and you're going to add an anti-IgG antibody, which will then result in agglutination. So the direct test asks the question, do I have red blood cells that are already coated with antibody? And the indirect test asks the question, does the patient's serum have the antibody? So that's important to understand that distinction. Another way by which we can get intravascular hemolysis is called microangiopathic hemolytic anemia. Microangio, small blood vessel, pathic, pathology. So there's a pathology in the small blood vessel that results in a hemolytic anemia. Now the idea here is that you've got a small blood vessel, and of course this blood vessel is lined by endothelial cells. And what happens in this case is that you get some sort of thrombus. It could be a platelet thrombus, it could be a platelet plus fibrin thrombus, which blocks the blood vessel partially so that when the red blood cells go across this blood vessel, they get sheared and they develop into cells that look like this, which are called schistocytes. And schistocytes are the hallmark of microangiopathic hemolytic anemia. Now, microangiopathic hemolytic anemia can be seen in a few contexts.
Oh my god, I just realized my camera's on. That's not good.
In a few circumstances. The first would be TTP, thrombotic thrombocytopenic purpura. And in this particular case, you get platelet thrombi, and it's due to the fact that the patient lacks an enzyme called Adams TS13. We've discussed this in detail in our coagulation lecture, so I won't repeat it here, but you can refer back there if you need to. In HUS, which is a sort of a sister disease, you also have platelet microthrombi, but in hemolytic uremic syndrome, i.e. HUS, it is due to a toxin produced by E. coli 015787. Again, we've also covered this in our previous discussions. In DIC, you get platelet plus fibrin thrombi, and the platelet fibrin thrombi would then again result in schistocytes. We've covered that previously. And in a fourth scenario called HELP, hemolysis, elevated liver enzymes, and low platelets, a pregnant woman can develop the microangiopathic hemolytic anemia within the liver due to the production of these thrombi as well. And we'll discuss that in more detail when we do the gynecologic lectures. But the idea here is that you've got a small vessel pathology that results in production of schistocytes and a hemolytic anemia. We can also get loss of red blood cell within the vasculature with prostatic heart valves, and that's because the valves crush the red blood cells, destroying them, and with aortic stenosis. The calcified degenerative valve will also, again, crush the red blood cells and destroy them. So these are some circumstances in which patients might get a hemolytic anemia inside the blood vessel. Again, I've already told you that microthrombi produce schistocytes on blood smear, so whenever you have a microangiopathic hemolytic anemia, you think about schistocytes, and this is the classic image of schistocytes that I've already presented in a prior lecture. Notice that it looks like a helmet, and that's the classic finding, is that you have points at either end of the cell with a shearing of the cell across the cytoplasm. Another way by which red blood cells can be destroyed is malaria. Malaria results in infection of the red blood cells and the liver with plasmodium, and it's transmitted by the Anopheles mosquito, and that's important to know as well. This is the classic finding. We will see little fragments of, or little organisms, malarial organisms present within the red blood cells. It's important to note that what causes the hemolysis is that the RBCs rupture as part of the plasmodium life cycle. So that each time the plasmodium undergoes its life cycle and begins to reproduce, eventually it'll cause rupture of the cell. What's interesting is that the rupture of the cell will result in fever, so that, for example, with Plasmodium falciparum, the patients get daily fever, whereas with Vivax and Ovale, they get fever every other day. So again, just allowing you to remember that in malaria, patients would also get a predominantly intravascular hemolysis. However, the spleen will also consume some of the infected red blood cells, and so there will be some extravascular hemolysis with splenomegaly. The final discussion that we want to have is anemias due to underproduction. And the idea here, again, is that you get decreased production of the red blood cells by the bone marrow, and it's characterized by a low corrected reticulocyte count. The etiologies of underproduction bone marrow include anything that causes a microcytic anemia or a macrocytic anemia will usually have a low reticulocyte count. So, for example, in iron deficiency anemia, the reticulocyte count tends to be low. In vitamin B12 and folate deficiency anemia, the reticulocyte count tends to be low. Renal failure will also result in low production by the bone marrow because there will be less erythropoietin produced. Reticulocyte count will be low. And if there's damage to the bone marrow precursor cells, that would also result in a low reticulocyte count because the progenitor cells are not functioning properly. One classic example would be parvovirus B19. We've talked about it several times already. This infects the progenitor red cells and then stops erythropoiesis, which then results in anemia, predominantly when there's pre-existing marrow stress. So you and I, if we got a parvovirus B19 infection, would probably be relatively asymptomatic, but a patient who's highly dependent on their reserve of bone marrow would show signs even with a minimal knockdown of their erythropoiesis or in particular their production of red blood cells. The treatment's supportive because parvovirus B19 is self-limited. Usually within a week to 10 days, the infection begins to resolve. Aplastic anemia is when you have damage to the hematopoietic stem cell. This results in a pancytopenia, i.e. low white count, low red blood cells, and low platelets with a low reticulocyte count because you're not making red blood cells. Etiologies include drugs and chemicals. There are some drugs and chemicals that can classically result in aplastic anemia. Viral infections can also do it. And last cause would be autoimmune damage. When a biopsy is performed in this particular case, the classic finding is that there is an empty marrow. This is the bone marrow. Here's a spicule bone. And all we see here is fat. Each of these circles represents adipose tissue or fat. And notice that there are basically no hematopoietic elements in this marrow space. So that's aplastic anemia. The treatment involves cessation of any drug that might be causing it, transfusions to support the patient, and marrow stimulating factors can be given in order to try to induce production of cells from whatever stem cells are present. So erythropoietin to drive the erythroid precursors to produce red cells, GM-CSF and G-CSF to drive the granulocytic precursors to produce granulocytes. Another possible treatment is immunosuppression. Recall that one of the etiologies of aplastic anemia is autoimmune, and so immunosuppression can potentially knock down that autoimmunity, allowing for the bone marrow to come back. And the final last resort would be to give a bone marrow transplant. The very last topic that I want to touch on is a myelophysic process. This is a pathologic process that replaces the bone marrow. So if there's some pathologic process that takes over the bone marrow, that would impair hematopoiesis because that's obviously where the cells are generated. For example, if the patient had metastatic cancer that diffusely replaces the bone marrow, that would impair hematopoiesis, resulting in pancytopenia. And that is called a myelophysic process. And so with that, we conclude our chapter on red blood cell disorders.
Holy shit. I'm not gonna lie, I did not retain any of that. Oh my god. I'm so cooked. Pancytopenia. Okay, I gotta go back. Ay, ay, ay. Hello? I think my Wi-Fi is being weird because of the snow or something. I'm just gonna let that load while I look through these notes. I have to go back. I need to review the difference between extravascular hemolysis and intravascular. Okay, so hemolysis is peripheral RBC destruction. Extravascular involves red blood cell destruction by the reticuloendothelial system. So macrophages of the spleen, liver, and lymph nodes. Okay. Intravascular involves destruction of red blood cells within vessels. Okay. By what, though? Well, guess it's not important. Okay, next we're gonna do chapter 3. Oh my god. Oh my god, 38 minutes? You've gotta be kidding me. Oh. Wait, did I have to watch 2 and 3? Is that what it says? Okay, part 1 is not needed. Thank god. Oh. Okay. Oh dear god. Bro, is this gonna load or what? Okay, whatever. Chapter 3. Principles of neoplasia. I need a sip of my coffee, bro. Okay.
Okay, welcome back. We're now going to begin Chapter 3, Principles of Neoplasia, and the first section in this particular chapter is actually entitled Neoplasia. Before we begin, just some basic principles. The word neoplasia, neo means new, and plasia means growth. And what's important to recognize concerning neoplasia is that it is unregulated, irreversible, and monoclonal. Now, these three features are important because it's these three features, the fact that the growth is unregulated, that it's irreversible, and that it's monoclonal. These three features help to distinguish neoplasia from hyperplasia or repair. Just as an example, hyperplasia, as you'll recall, occurred when there might be an increase in stress on an organ. For example, a woman becomes pregnant, the uterus, the smooth muscle of the uterine wall actually undergoes hyperplasia. However, hyperplasia is regulated. It's regulated by the physiology of the pregnancy. It's reversible. When the woman delivers, her uterus will again shrink down to normal size. And it's polyclonal. And by polyclonal, what we mean is that multiple cells produce daughter cells, which then subsequently results in the hyperplasia. Whereas cancer is monoclonal. We're going to talk about monoclonality in a moment. So again, these are three very important features of neoplasia. Now, as I mentioned just a moment ago, monoclonal refers to the fact that all the tumor cells actually arise from one single progenitor cell, one single mother cell or one single father cell. And that's what the term monoclonal means. So as I've stated here, the neoplastic cells are derived from a single mother cell. Clonality can be determined by G6PD isoforms, and this actually is a very high-yield principle, which we should probably take a moment to highlight. So what I'm going to do here is actually just create a whiteboard and then spend a moment just explaining what we mean by this. So let's go back and pretend for a moment that we are looking at the uterus of a female. And let's just imagine that this uterus actually is comprised of 4 cells. Now, obviously, the female uterus is not made up of 4 cells, but we can just imagine just for the purposes of illustration. One of the important enzymes that is present on the X chromosome in a female is G6PD. And I'm going to take a moment to remind you that G6PD is actually X-linked, and that there are multiple isoforms that exist across the population. So, for example, one individual, there may be a G6PD-A, a G6PD-B, a G6PD-C, a G6PD-D, etc. There are dozens of variants of these dozens of isoforms of G6PD. Now, any single female in the population will have only inherited one copy of G6PD, one isoform of G6PD from their mother, and one isoform of G6PD from their father. So let's pretend a woman inherits G6PD-A from the mother or the father, and G6PD-B from the other parent. So basically, each of the cells in that female, because she's got 2 X chromosomes and G6PD is X-linked, each of the cells in that female will express both G6PD-A and G6PD-B. So, for example, if this uterus that we've drawn up here is actually made up of 4 cells, then these 4 cells would be expressing G6PD-A and B, and each of them would express the 2 isoforms because each cell contains 2 X chromosomes. So it would look something like that. Now, the next important concept to bear in mind is that in a female, one X chromosome is going to be randomly inactivated, so that in any particular cell, there would only be one active variant of G6PD. And you know that the inactivation of the X chromosome is actually random. So, for example, if we had these 4 cells that I've drawn up here, it may be that in this particular cell, G6PD-B is inactivated, or that X chromosome is activated. It may be that in this cell, this X chromosome is inactivated. It may be that in this cell, this X chromosome is inactivated, and that in this cell, this X chromosome is inactivated. Now, X chromosome inactivation is going to be random, so that in the end, if we were to look at all the cells present within the female's uterus, for example, the ratio of G6PD-A to G6PD-B would be 1:1. Now, let's just imagine for a moment that a woman develops hyperplasia of her uterus, okay? So she becomes pregnant, and the uterine wall undergoes hyperplasia. And when it undergoes hyperplasia is defined as an increase in the number of cells. So let's say that, for example, this particular cell produces 2 daughter cells, and this particular cell produces 2 daughter cells, and this cell also produces 2 daughter cells, and this cell also produces 2 daughter cells. Now, the daughter cells would show the exact same active isoform of G6PD as their mother cell. So these 2 cells would produce G6PD, would be expressing G6PD-A. These 2 cells would be expressing G6PD-B, these two cells would express G6PD-A, and these two cells would express G6PD-B, because obviously the mother cell also expresses G6PD-B. So in hyperplasia, which is polyclonal, i.e., the cells are derived from multiple individual cells, the ratio of G6PD-A is going to be maintained, because here we can see that there are 1, 2, 3, 4 of G6PD, four cells that are expressing G6PD-A, and 1, 2 scenario.
I get it, bro.
Again, we've got 4 cells present within the uterus. These are the smooth muscle cells of the uterus, and we said that this is perhaps expressing G6PD-A, this one expresses G6PD-B, this one expresses G6PD-A, and this one expresses G6PD-B, so that the ratio is approximately 1 to 1. Now, in the case of neoplasia, all the tumor cells are this concept that one cell produces all the tumor cells. That is actually the idea behind monoclonality, i.e., there is one mother cell that's producing all these baby cells, and a way by which we can prove the way by which we can prove monoclonality in a female would be to look at G6PD isoforms. And so if we see that the tumor is composed of one isoform of G6PD, then that would indicate that we're dealing with a monoclonal proliferation, hence we're dealing with neoplasia. Whereas if we saw that the G6PD isoforms were expressed in a roughly 1-to-1 ratio, then we would know that we're actually dealing with a polyclonal proliferation, which would basically be hyperplasia. So I hope that that's clear, because that's a very high yield concept that shows up on examinations. And so let's go back and now read what we have here in the text. So we say that one of the key characteristics of tumor is that it is monoclonal. So again, one chromosome. And so we meant all neoplasia, and we're looking at their lymph node. Now let's pretend that this the concept. Let's play the same game, but this time pretend that there is an individual, and we're looking at their lymph node. Now let's pretend that this individual, and that is that all neoplasia, whether it be immunoglobulin light chain phenotype. And this is a way by which we can determine the clonality of B cells. This is high yield, and so it's worth taking a moment to understand the concept. Let's play the same game, but this time pretend that there is an individual, and we're looking at their lymph node. Now let's pretend that this individual's lymph node is made up of 4 cells. Okay, obviously it's not, but for the purposes of illustration, it makes it easy. So if the patient actually has 4 cells in their lymph node, you should recall that the B cells present within the lymph node express immunoglobulin, and that immunoglobulin is comprised of both heavy chain and light chain. Now, the light chain for each individual B cell will either be kappa or lambda. There's only 2 choices. Either a B cell expresses kappa or it expresses lambda light chain. And generally speaking, the ratio of kappa to lambda cells within the lymph node or within any collection of lymphocytes is 3 to 1. So that if we had 4 cells making up this lymph node, 3 of the cells would express kappa light chain, and 1 of the cells would express lambda light chain. All right, now let's pretend that a patient gets an infection. And when they get an infection, what's going to happen is that they're going to get hyperplasia of the cells of the lymph node, because there's going to be a response to the infection, and the B cells are going to proliferate. And we know that when we get infections, that the lymph nodes become bigger. And so if the lymph node becomes bigger, we could ask the question, why is the lymph node bigger? What type of proliferation is occurring? And if there was an infection and the proliferation was due to hyperplasia, then what we would expect is that in hyperplasia, each of these cells would contribute, because it's polyclonal, each of these cells would contribute additional cells. So for example, if this is a kappa light chain B cell, then each of these cells is making additional cells. Let's just draw these here. And each of the additional cells is going to have the same light chain ratio of 3 to 1.
Basically what he's trying to say. So these light chains can either express kappa or lambda. Normally, the ratio of kappa to lambda is 3 to 1. But if it's a neoplasia, the ratio will increase to over 6 to 1, or it'll be inverted, so the kappa to lambda ratio would be 1 to 3, which would indicate a lymphoma. So same thing, hyperplasia is polyclonal. You would have that normal 3 to 1 ratio of kappa to lambda. And neoplasia is monoclonal, so you would have, I guess, more kappa, like over 6 to 1 ratio of kappa to lambda, or it's inverted, so less kappa, more lambda, basically is what he's trying to say. It's too long of an explanation. I feel like I don't need this shit, bro.
B cells is determined by immunoglobulin light chain phenotype. Okay, now, going back to a general principle, when we have neoplasia, neoplasia can be benign or it can be malignant. Let me make something very clear because sometimes this is misunderstood and it's missed on examinations as well. Both benign tumors or neoplasia and malignant tumors or neoplasia, both of these are monoclonal. Whether it be a benign tumor or it be a malignant tumor, neoplasia, generally speaking, is monoclonal. All right, so I want to highlight that point. Now, benign tumors, one of the key characteristics of benign tumors is that they tend to remain localized in the tissue in which they grow, and they absolutely do not metastasize. That's a key characteristic of benign tumors. Malignant tumors are also called cancer, and a characteristic of malignant tumors is that they invade locally, and they have the potential to metastasize. What do I mean by potential to metastasize? Meaning that in a subset of patients, those tumors will metastasize, but it doesn't need to metastasize in every single patient. So, for example, if a woman has breast cancer and it's localized to the breast, if that cancer has the propensity to metastasize in patients, then we would still call it cancer, even though it hasn't metastasized in that individual patient. So it simply has the potential to metastasize in any given patient. So again, this is another general principle concerning neoplasia. Now, if we go a step further, we can go, and given that we understand that tumors can be benign or malignant, we should then understand that tumors will have particular lineages of differentiation. And the way I think about this is, you've got four major tissues within the body. You've got epithelium, which are the cells that line the surface of the body. So they line the skin, they line the gut, they line the esophagus, they line the urogenital tract. All right, those are epithelial cells. You've got mesenchyme. What is mesenchyme? Mesenchyme is a connective tissue in the body. So the mesenchyme includes fat, blood vessels, bone, cartilage, okay? It's your soft tissue, basically. Your soft tissue, your bone, your cartilage. That's mesenchyme. There are lymphocytes in the body, and then there are melanocytes in the body. And each of these individual types of cells can develop tumors, and when they develop tumors, those tumors can be benign or malignant. So, for example, a benign tumor of epithelium, when it produces glands, is called an adenoma. And a malignant tumor of epithelium, when it produces glands, is called an adenocarcinoma. A benign tumor of epithelium, when it creates papillary finger-like structures, is called a papilloma. And a malignant tumor of epithelium, when it creates papillary finger-like structures, is called a papillary carcinoma. And what do I mean by papillary finger-like structures? Well, it basically means that you've got this growth of epithelial cells, so these are the epithelial cells, and that they overlie a connective tissue core with a blood vessel in the center. So there's a connective tissue core with a blood vessel in the center. And so those are papillary growths, and papillary growths, when they're benign, they're called papillomas. When they're malignant, they're called papillary carcinomas. Mesenchymal tissue can also be benign or can produce tumors that will be benign or malignant, and it's going to be named based on the type of tissue that it forms. So lipo means fat, and oma means mass. So a benign tumor of fat is a lipoma, and lipo, again, means fat, and sarcoma means malignant mesenchymal tissue. And so a malignant tumor of fat would...
Holy shit. Now I know. I've always been like, what the hell's the difference between oma and carcinoma, whatever. Anyway, whatever, he goes to the table. Oh my god, bro.
We will cover it as we go through the organ systems again. Now, epidemiology is important to understand. The examiners like to go after epidemiology. I think it's important for you to be familiar with a little bit of epidemiology as you go through your medical training. And so let's just mention a few important points. First of all, cancer is the second leading cause of death in both adults and children. All right, and it's important to know that generally speaking, the major causes of death in adults are, number one, cardiovascular disease. So that probably tells you that cardiovascular disease is important to be familiar with. You're going to see a ton of it in your careers, and you're going to see a ton of it on examinations. Cancer is a second cause of death in adults, second leading cause of death in adults, so we should be well aware of cancer, and we're going to see it commonly. And the third is cerebrovascular disease. And so these are the three leading causes of death in adults. Causes of death...
Wait. But in the textbook it says chronic respiratory disease as the third one. Huh? Okay. Well, I'll just put both, I guess. Well, actually, maybe this is just old and it's changed. I don't know.
In children, number one, accidents. And accidents, unfortunately, are a cause of death that can often be avoided, but are overlooked. And so we need to be particularly careful about making sure that we as physicians when we have access to a pediatric population, ensure that patients are particularly careful with their children. For example, making sure that children are in car seats and wear their seatbelts, etc. But anyway, accidents are the number one cause of death in children. The second leading cause of death in children is cancer, and the third leading cause of death in children is congenital defects. Taking the epidemiology one step further, we can ask ourselves, what are the most common cancers in adults? Now, these types of tables in which the most common cancers in adults are discussed, basically what you should know is that these exclude skin. So squamous cell carcinoma and basal cell carcinoma of the skin are very common tumors, but we're going to exclude them because although they're malignant, they rarely metastasize, and they're more of a nuisance than anything else. They quickly reveal themselves because they're on the skin, and they can easily be treated and are not commonly a cause of death. And so basically, we're going to remove those tumors from the list, and we're going to talk about the most common cancers in adults by incidence and by mortality. So the three most common cancers in adults by incidence are, number one, breast or prostate, obviously breast in a female and prostate in a male. Number two, lung. That's the second most common cancer by incidence. And number three, colorectal. So these are the sort of the most common cancers by incidence. Now, if we were to look at this list by mortality, by those cancers that actually cause death, then lung jumps up to number one, and then breast in the female and prostate in the male is number two, and in prostate, and in particular because cancer on the list sort of brings up really can wreak havoc in that patient. That is one of the greatest ways by which we can serve our patients, because really the story of cancer is the story of the best way by which to deal with a cancer is to actually detect it either before it becomes a cancer and then remove it, or to detect it before it produces clinical symptoms. And I'm going to highlight that in a moment, but let's just look at this list again now from a different perspective. So when you think about breast, we have a method of screening for breast, right? We can do mammogram, we can do physical exam. Prostate, we have a mechanism for screening for prostate, although it's a little bit debated. We currently screen with PSA and digital rectal exam. Colorectal, we have a mechanism of screening for colorectal. We do Hemoccult testing of the stool, and we also do colonoscopy after a certain age. So each of these tumors can be caught relatively early. And because they can be caught relatively early, we can do a pretty good job of reducing the mortality. However, in the case of lung cancer, there is no screening mechanism. Lung cancer usually presents late in the course. There is no practical screening methodology, and so therefore it pops up to number one as far as mortality is concerned. And to me, one of the most interesting statistics is that if I asked you what was the 5-year survival for lung cancer 30 years ago, the answer would be about 15%. And if I ask you what's the 5-year survival for lung cancer today, the answer is about 15%. It hasn't changed very much. There's been a little bit of an increased survival due to improved surgical technique, but for the vast majority, for basically, generally speaking, the survival of lung cancer really hasn't improved over the last 30 years. And that's despite the fact that we've got all these designer drugs and understanding of molecular biology. But I think really the underlying principle or premise there is that we really don't have a practical method to screen for lung cancer, and hence we're not picking up lung cancer early. And because we're not picking up it's worth having a discussion of screening. Idea in symptoms arise. Okay? And so one of the things that examiners like you to know is how many divisions have to occur before the average tumor reveals clinical symptoms. And the answer is that there are about 30 divisions that will occur before the earliest clinical symptoms arise in cancer. So that's one important point. And that's what I've stated here. Cancer begins as a single mutated cell, and then there's about 30 divisions before the earliest clinical symptoms arise. Now, what's important to note is every time a cancer divides, all right, with every division, there's going to be increased mutations because cancers are growing out of control. And so the DNA is not being repaired, mutations are being picked up, check systems are basically not able to control the cell. And so with every single division, there's going to be increased mutations. And so one important principle or general idea is that if you have a cancer that doesn't produce symptoms until very late in the disease, it will have undergone additional mutations. It will have undergone additional divisions, which will then lead to additional mutations. And so whereas the average tumor or the tumor that reveals the earliest clinical symptoms will have divided 30 times and will then be detected, there are some tumors that really get detected very late. For example, ovarian carcinoma. The ovary has a large area to grow before any clinical symptoms arise, and because those clinical symptoms are not seen, and because clinical symptoms are not produced until very late, sometimes those tumors can grow and extend far beyond these 30 divisions, and every time they divide, they're picking up mutations, and so ovarian carcinoma, generally speaking, has a pretty poor prognosis. Similarly with pancreatic carcinoma. The pancreas has a large space to grow before clinical symptoms arise. The pancreas has a large reserve before the tissue damage can reveal itself. And so pancreatic carcinoma has a horrible prognosis. And same thing with lung cancer. The lung has a tremendous reserve, and a cancer can grow significantly before clinical symptoms actually arise. And so these tumors will tend to have a worse prognosis. And that's what I basically stated here, that cancers that are detected late, they tend to have a poor prognosis. All right, so that's important to know. Now, what's the goal of screening? Remember that I told you that tumor develops from a single cell, and that single cell becomes 2 cells, which becomes 4 cells, which becomes 8 cells, which eventually produces clinical symptoms, right? And every time these divisions occur, there's going to be an increase in mutations. Okay, so what is the goal of screening? Screening has 2 separate goals. The first goal is to catch dysplasia before it becomes cancer, i.e., even before.
Okay. Just goes through all the tests, screening tests. Basically, he's trying to say screening is meant to catch dysplasia before it becomes a carcinoma, or if it's already a carcinoma, catch the carcinoma before it gets worse or like the clinical symptoms arise. Common screenings are pap smear for cervical dysplasia, to detect it before it becomes carcinoma. Mammography or mammogram detects basically breast cancer before it invades, or invasive carcinoma before it becomes clinically palpable. Prostate-specific antigen, PSA, and digital rectal exam detects prostate carcinoma before it spreads. Oh, so these are like kind of catching it at different points, huh? Does he say that?
Colonoscopy or outside of the prostate, and the way by which we can detect them is
Whatever, I guess it doesn't matter that much. What the fuck? Colonoscopy detects colonic adenoma before it comes carcinoma, or carcinoma before it spreads. Okay. Cool. I'm not sure how important it is to know like exactly when it'll catch it or not.
mechanism of screening for cancer. Another important screening test that we can use is PSA and digital rectal exam. Now, what's the idea here? The idea here is that recall that if this is the prostate, and running through the center of the prostate is a urethra, the prostate cancer tends to grow in the posterior peripheral aspect of the prostate. In the posterior peripheral aspect of the prostate, and so it's a relatively silent disease because it doesn't really produce urinary symptoms. Now, the urethra runs through the center of the prostate. Do you know what disease process involves the center of the prostate? Very good. BPH. BPH involves the center of the prostate, and BPH will compress the urethra and produce urinary symptoms. However, prostate cancer.
Okay, bro, I don't really care. Anyways.
Okay, welcome. Oh. Okay, now once you.
Okay. Okay, we could skip the first part. Next part is. Where does this start? DNA mutations eventually disrupt key regulatory systems. Where is that? Oh. Okay, well, I don't know what the first video goes through, but basically this starts at 1B of the carcinogenesis section. And the first part of basic principles just says cancer formation is initiated by damage to DNA of stem cells. Okay. Damage to DNA of stem cells. The damage overcomes DNA repair mechanisms, but is not lethal. Carcinogens are agents that damage DNA, increasing the risk for cancer. Important carcinogens include chemicals, oncogenic viruses, and radiation. Okay. And radiation. Alright, and then this is where we start this video. 28:53. Oh my god. I want to go at, like, I wish I could go at 2 times speed, but, like, my brain cannot comprehend. So. And then I was doing 1.5, but low-key that's also a little fast for me. Okay. Oh god.
You've gotten to the point where you understand that there are multiple carcinogens that can damage DNA, then the next point that you have to understand is that there are particular regulatory systems that, when damaged, will certainly increase the risk for tumor growth and progression. And so the next discussion that we want to have concerns these key regulatory systems. So the 3 key regulatory systems that we're going to discuss are, number 1, the proto-oncogenes, number 2, tumor suppressor genes, and number 3, regulators of apoptosis. These are 3 key systems that can be disrupted by carcinogenic agents. And these are very high yield, very important. There's a significant amount of biochemistry that goes into them. So what we're going to do is we're actually going to discuss each of these in the subsequent slides. All right, what are proto-oncogenes? Proto-oncogenes are genes that are essential for cell growth and differentiation. All right, and when mutated, so all our cells normally have proto-oncogenes, and those proto-oncogenes are necessary for cell growth and differentiation. However, when a proto-oncogene gets mutated, then it becomes something called an oncogene. And oncogenes, what they do is they lead to unregulated cell growth. So oncogenes lead to unregulated cell growth. Here are the key categories of oncogenes. The categories of oncogenes include growth factors, growth factor receptors, signal transducers, and cell cycle regulators. I think the best way to understand this notion of oncogene.
Note, there's another category added, nuclear regulators, that's in the textbook that he did not mention.
Is to go back and just remind ourselves of normal cellular growth. And so I'm going to go ahead and generate a whiteboard here and just draw you a simple picture to remind you of something. Let's pretend that this is a cell, okay? And this cell has a growth factor receptor on its surface. Now, when this cell needs to divide, and there will be times when a cell needs to divide, either because it's constantly turning over or because there is some sort of repair or regeneration, etc. When the cell needs to divide, what happens is that growth factor comes in, and growth factor binds the growth factor receptor. And growth factor binds the binding of growth factor to growth factor receptor sends a signal, and this signal is carried by something called a signal transducing molecule. And so a signal transducer will carry the signal to the nucleus, and within the nucleus, cell cycle regulators and nuclear regulators will get activated, which will then cause the cell to cycle through G1S, G2, M, and that's the normal cell cycle. All right. So this is sort of the normal growth sequence, and each of these steps involves oncogenes. So oncogenes include, or why don't we say, because we're discussing the normal, each of these steps involves proto-oncogenes. So one type of proto-oncogenes would be the growth factor. Another type of proto-oncogene would be the growth factor receptor. Another type of proto-oncogene would be the signal transducer. And then another type of proto-oncogene would be the cell cycle regulators. So this is sort of the normal. Now, in each of these cases, mutations in any one of these steps or any one of these subtypes of or categories of proto-oncogenes can result in the formation of an oncogene and can then be associated with formation of a tumor. And that takes us then to this table, which is present within your text. And again, it's a fairly dense table, and so it might be easiest for you to follow along in your text here, and then to write in the margin some of the notes or some of the points that I may make. So let's take this step by step. All right, the first category of oncogenes are growth factors. So that's way up here at the top of this table. And one of the classic examples of this is astrocytoma, which is a tumor of the astrocytes of the brain, which are a type of glial cell. All right. Now, I don't want to get into the details of what an astrocytoma is here, but I want to highlight to you that in this particular case, what happens is that there is overexpression due to mutation of this growth factor, platelet-derived growth factor B, and platelet-derived growth factor B gets overexpressed, which then drives the formation of an astrocytoma. So let me do this by illustration. So let's pretend that this is a cell. This is an astrocyte, and let's pretend that this astrocyte simply has a platelet-derived growth factor receptor, okay? And normally, when platelet-derived growth factor binds the receptor, the astrocyte then divides. Now, what happens in this particular case is that you get a mutation so that the astrocyte begins to overproduce platelet-derived growth factor. And if the astrocyte begins to overproduce platelet-derived growth factor, it can actually then sort of swing around and hit the same cell through this signaling mechanism, which then results in overgrowth of the cell, i.e., the extra platelet-derived growth factor keeps hitting the receptor. The receptor then sends signal to the nucleus. The nucleus then recognizes that it needs to divide, and so this cell grows. And this becomes sort of a vicious cycle in which the cell keeps growing in an unregulated manner and eventually produces an astrocytoma. And so that's the classic example where patients have a overexpression of platelet-derived growth factor, which then, in an autocrine loop, results in the overgrowth of astrocytes, producing an astrocytoma. So that's the first classic example of a oncogene mutation, or a mutated gene, i.e. oncogene, resulting in formation or being associated with formation of a tumor. All right, so that's one example. Another example would be growth factor receptors. Another example, growth factor receptors. So again, we can go back to our diagram, and we can remind ourselves that if this is a cell, and the cell is expressing a growth factor receptor, right? Here it is, it's expressing a growth factor receptor. When growth factor comes in, all right, if normally what would happen is growth factor would bind the receptor, signal would be sent, and the cell would then divide. However, if you've got way too many receptors, let's say there's a mutation and there's overexpression of this receptor, then a simple stimulus of growth factor is going to result in 1,000 times or 100 times signal to this cell to grow and divide, and so this cell will begin to grow and divide out of control. And that will eventually result in the formation of a tumor. Now, what are some important growth factor receptors that can become mutated, and what tumors are they associated with? Well, one of the very high yield growth factor receptors is HER2/neu. All right, HER2/neu is a growth factor receptor. It's an epidermal growth factor receptor that is amplified in a subset of breast cancers. And why is this important to be familiar with? Because it ties back into pharmacology. And you'll remember from pharmacology that there is a designer antibody called trastuzumab. The other name is Herceptin, but there is a designer antibody called trastuzumab, which is designed against the HER2/neu receptor. And so patients who have overexpression of HER2/neu, i.e. amplification of HER2/neu, that results in breast cancer, in a subset of breast cancer, can be treated with trastuzumab. And there's a classic examination question.
Trastuzumab? I'm gonna write that down.
In which you could be asked, a patient, I don't know, we can make up a question that's sort of along the same principles. Patient comes to you having read, a patient with a history of breast cancer comes to you having read an article in the newspaper in which she sees that there is a new treatment for breast cancer that is designed against, that is a designer antibody against a growth factor receptor. So we could ask them, which of the following tests would be important to perform in order to determine whether or not she should be treated with the drug? A, estrogen receptor, B, progesterone receptor, C, HER2/neu, et cetera, et cetera. And obviously the answer would be HER2/neu. So it's important to be familiar with, and I would basically say that in a subset of breast cancer, there is amplification of the HER2/neu growth factor receptor. And so that's an important growth factor receptor to be familiar with. Another very important growth factor receptor to be familiar with is RET. And the key association with RET is medullary carcinoma of the thyroid, in particular, medullary carcinoma of the thyroid associated with MEN2A and 2B. Now, this requires a little bit of discussion. So what's MEN? MEN is multiple endocrine neoplasia. It is a syndrome in which patients develop tumors in multiple endocrine organs. And it can be divided into MEN1, MEN2A, and MEN2B. And in MEN2A and 2B, one of the common tumors between each of those 2A and 2B is medullary carcinoma of the thyroid. Now, this is a very high yield association because if you suspect MEN2A or 2B in a patient, let's say a patient has some of the other features of MEN2A or 2B, like pheochromocytoma, mucosal neuromas, as would be seen in MEN2B, then those patients in whom you suspect MEN, you can do RET studies. And if the patient has a RET mutation, then what you'll actually do is prophylactically remove the thyroid, i.e. the thyroid will be removed before a tumor can actually form. And because medullary carcinoma of the thyroid could potentially kill the patient. And so testing for RET mutation is a very important feature of how we might deal with patients who have familial or MEN2A or 2B associated medullary carcinoma of the thyroid. So that actually is a very high yield association. And I'm going to give you much more detail when we do the endocrine lectures. I'm just, again, planting some seeds. Another important growth factor receptor is the KIT growth factor receptor. And a mutation in the KIT growth factor receptor is associated with something called gastrointestinal stromal tumor. And that's an important association to be familiar with. Okay. The next group of oncogenes are signal transducers, and the idea here is that after the growth factor receptor is bound, it will send a signal using a transducer to the nucleus. Now, imagine for a moment, let's go back to our whiteboard. Let's say that this is the cell, and we've got this receptor here. If growth factor binds the growth factor receptor, then a message will be transduced, and that message will go to the nucleus. Now, normally, for one growth factor receptor molecule, you only want one growth factor receptor signal sent via the messenger. Let's pretend that the messenger gets mutated so that the messenger keeps sending signal to the nucleus to grow. If there's massive signal heading to the nucleus to grow, the nucleus will obviously cause the cell to divide, and multiple divisions will eventually result in the formation of a cancer. And so that's the idea in this particular subtype of oncogenes, and that is that if there are mutations in signal transducers, that'll result in the formation of a cancer. And so what are some classic ones to be familiar with? Well, the first and probably the most important is the RAS signal transducing protein. Why is this important? Because it is commonly mutated in a large number of cancers. In fact, I think up to 70 to 80% of human tumors actually have have a RAS mutation associated with that tumor. So it's seen in multiple carcinomas, it's seen in melanoma and in lymphoma. So a broad range of human cancers actually have a mutation within the RAS signal transducer. This then requires us to go into a little discussion of biochemistry. So I'm going to take a step back here. This discussion is written in your book, but I'm going to go ahead and present it here because it's the perfect place in which to have this discussion. And so I'm going to simply go back and produce my whiteboard and just let you know a little bit about RAS. So what's the idea with RAS? Let's pretend that this is a cell, okay? And the cell clearly has a receptor, right? And growth factor would come in, and growth factor would bind that receptor. Now, when growth factor binds the receptor, one of the molecules that can be associated with the receptor is actually called RAS, R-A-S, okay? So that's RAS. Now, when RAS is associated with a receptor, it usually sits in its off state, which is basically RAS associated with something called GDP, all right? Now, the moment that growth factor receptor binds the receptor, the GDP gets kicked off, and instead, RAS gets associated with GTP. And when RAS gets associated with GTP, the RAS-GTP complex then can send message down to the nucleus. And that's the key notion of that's the key way by which RAS works. Now, because RAS GTP, when associated together, has the ability to carry the message down to the nucleus, you don't want too much message sent to the nucleus, you simply want a message sent to the nucleus. And so RAS also has the ability to cut away one of the phosphates so that the GTP becomes GDP, allowing RAS to become shut off. And RAS has the ability to cut away that phosphate. This is so important that there is an additional molecule associated with RAS, which is called GAP, which is GTPase-associated protein. And the GTPase-associated protein helps RAS to cleave that phosphate to shut off the on form or the active form of RAS. Now, in RAS mutations, one of the common mutations is the mutation in this associated protein. So that if this GTPase-associated protein is missing, RAS is going to have difficulty shutting off GTP, or converting GTP to GDP, and therefore will not be able to shut off. And so when RAS remains associated with GTP, this will send excess signal to the nucleus, causing the cell to overgrow, right? And that's the key issue concerning RAS. So the biochemistry of RAS is important, and the fact that it's associated with so many human cancers is important and makes this molecule high yield. And that's why I spent a little time going over it. Okay, so that's RAS, and let's see what we say here in the book. The RAS-G family is a GTP binding protein, okay? And a mutation within RAS, in particular within the GTPase activating protein present within RAS, can result in multiple human cancers. All right, next important signal transducer is the ABL signal transducer. This is a tyrosine kinase. When there's a 922 translocation, there is overactivation of this tyrosine kinase, and this overactivation classically results in CML. So this is another example of overexpression of a signal transducer. Now, it's important to note that the 922 translocation defines CML. It defines CML, but also I would be aware of the fact that the 922 translocation is also seen in some types of ALL, and in particular in adult ALL. Now remember that ALL is basically a disease of children. However, in some in adults that form ALL, there is an increased propensity to have this translocation, a 922 translocation. It's also called pH positive ALL, i.e. Philadelphia chromosome positive ALL, because the 922 translocation is also called the Philadelphia chromosome. And recall that ALL actually has a relatively poor prognosis, i.e. ALL with a 922 translocation has a relatively poor prognosis. So that's another type of oncogene that can be mutated, i.e. signal transducers. The next type of oncogene that can be mutated are the nuclear regulators. And the nuclear regulators are basically a group of transcription factors, and these transcription factors go to the nucleus and cause upregulation of genes necessary for growth, okay? And so those are nuclear regulators. And the most important nuclear regulator is MYC, MYC. That's the most important nuclear regulator. And what I would remind yourself of here is that the three key MYCs to be familiar with are c-MYC, which is associated with Burkitt's lymphoma, N-MYC, and the N helps you to remember neuroblastoma, and L-MYC, and L-MYC is associated with small cell lung carcinoma. So the L will help you to remember lung. So each of these are transcription factors. MYC is a transcription factor, and upregulation or overexpression of the MYC gene will result in overproduction of growth promoting proteins, and that will result in overgrowth, increasing the risk for development of a particular type of cancer. Now, one thing that I would like to highlight here is the fact that when you have a c-MYC translocation, that will result in Burkitt lymphoma. All right, and it's important to note here that the c-Myc the mechanism by which c-Myc is overexpressed in this particular in a Burkitt lymphoma is usually a translocation between chromosome 8 and chromosome 14. This requires a little bit of discussion, and so I'm going to again create a whiteboard to highlight some of this, highlight important principle here. Okay, now let me just remind you that Burkitt's lymphoma is actually a lymphoma of B cells. That's important to note, and that B cells normally express immunoglobulin heavy chain.
Oh,
right, so this is
what that
immunoglobulin
was.
heavy chain, and immunoglobulin heavy chain sits on chromosome 14. All right, so imagine that this gene is basically on. Okay, and let's say that the patient gets a translocation with the MYC gene, which in this particular case is on chromosome 8, and so this translocation will result in the switching of immunoglobulin heavy chain with MYC, so that when MYC sits in this position, so this now is going to become MYC because of the translocation, MYC will also will actually be turned on because this position in the chromosome or this location in the chromosome is an on location in a B cell. And so what will happen by this translocation is that there will be massive overproduction of MYC, and that massive overproduction of MYC will result in massive growth of the tumor. In fact, do you recall, or maybe you haven't studied yet, and so I'll have to tell you, that Burkitt's lymphoma, one of the key histologic findings in Burkitt lymphoma is called a starry sky appearance. And the idea behind the starry sky appearance is that the tumor cells represent the sky, and the tumor cells are very blue, but the stars, the little white areas that are interspersed between the tumor cells, those white areas actually represent areas of macrophages eating cells that are dying. And the idea here is that the cells are growing so rapidly that they actually grow and die, and they grow and many of them die, and so the macrophages consume them as they're dying, producing that starry appearance in the background of the blue lymphocytes. Anyway, the idea here is that overexpression of MYC results in massive overgrowth of the cells, and the mechanism by which MYC is overexpressed is that it gets translocated onto, in this particular case, chromosome 14. All right, so it is important to be familiar with the fact that MYC sits on chromosome 8, and that it can be translocated to chromosome 14, which is the immunoglobulin heavy chain locus, and then eventually resulting in overexpression. All right, so I would say that that's pretty much what I would like to say about nuclear regulators, and I'm going to, by the way, rediscuss Burkitt's lymphoma when we do the white blood cell lecture. Okay, so now let's go to the final group of oncogenes, and these are the cell cycle regulators. And so it's important to, sorry about that, cell cycle regulators, right? And it's important to note that the cell cycle regulators are proteins that assist movement through the cell cycle. So let's go back and create a little whiteboard. Remember that cell cycle basically consists of G1, G2, and M. Now, sorry, G2 and M. Now, important to note here that the G1 to S phase is the most highly regulated of the cell cycle. And the idea here is that before you put a cell into S phase where the DNA is going to be copied, you actually want to make sure that, number one, the cell should be going into S phase, and number two, that the cell goes into S phase without carrying any mutations in its DNA, because you don't want to pass bad DNA onto the offspring. And so G1S is highly regulated, and cell cycle, G1S is, why don't I go back? The entire cell cycle is highly regulated, in particular G1S. So that's basically what I'd like to say there. Now let's go back and talk a little bit about these cell cycle regulators. So the two important cell cycle regulators to be familiar with are, number one, cyclin D, all right, and its association is with mantle cell lymphoma. All right, so cyclin D1 with mantle cell lymphoma. Now again, you need to know for board examinations and generally speaking that mantle cell lymphoma is basically due to an 11-14 translocation. So let's go back and create a little whiteboard and again highlight the same principle. So mantle cell lymphoma is a lymphoma of B cells. All right, actually, why don't I take a step back? Let's create another whiteboard and just explain something. What is a mantle cell lymphoma first? So here's a lymph node. And remember that within the B area of the lymph node, the B area is the cortex of the lymph node. That's where the B cells live. Within the B area, you have follicles. So this is a follicle. And outside of the follicle, you have a region called the mantle. All right. And outside of the mantle, you can develop a region called the margin. So these are sort of the three key regions that can be seen in the B area. So from each of these regions, we can get a tumor. For example, we can get a follicular lymphoma, a mantle cell lymphoma, and a marginal zone lymphoma. Now, mantle cell lymphoma, which is what we're now talking about, and so let's create another whiteboard. Mantle cell lymphoma is driven by something called the translocation 11-14. Now, what happens there? Well, these are B cells, and B cells normally are overexpressing immunoglobulin heavy chain, which sits on chromosome 14. Okay, and imagine if cyclin D, all right, which sits on chromosome 11, gets translocated to the immunoglobulin heavy chain spot, so that now what's sitting here is cyclin D, then you're going to get overexpression of cyclin D. And what does cyclin D do? Cyclin D allows the cell to go from the G1 to the S phase. All of this is high yield, shows up on examinations. What do I mean by all of this? Well, first of all, you need to know that in mantle cell lymphoma, you get expansion of the mantle. So, for example, sometimes they give you a description on an examination where they say that a biopsy of the lymph node is performed and it shows expansion of the region next to the follicle. So what's the region next to the follicle? The mantle. So that's one important thing to know about mantle cell lymphoma. Another important thing you have to know is a translocation. It's an 11-14 translocation. You need to know that on chromosome 14 is immunoglobulin heavy chain, and that's the region where the translocation occurs, and that the key gene that's being translocated is cyclin D1. And that cyclin D1 is important to go from the G1 to the S phase. That's also an important biochemistry question. I remember vividly that on one occasion, I tell my students, and I'm telling you, you're a student, that I really see the board exams and other examinations, if they're well written, as thinking exams. And one of the students once came up to me and complained and said, well, I had a really foolish question on my exam where I was asked about, on what chromosome is cyclin D1? And, he was arguing with me saying that, well, see, that's not really a thinking question. That's a nitpicky fact memorization question. Well, actually, in a way, it is kind of a thinking question, because if you know that the key translocation in mantle cell lymphoma is actually an 11-14 translocation, and you know that on chromosome 14 is immunoglobulin heavy chain, then you can kind of go back and derive from that cyclin D1 is on chromosome 11, because cyclin D1 is this key gene that's involved in the 11-14 translocation. So anyway, basically what I want to get at is the fact that you do need to be familiar with cyclin D1, you do need to know about the 11-14 translocation, and that it is associated with mantle cell lymphoma.
I disagree.
And so that's probably the key points that I'd like to give you from this particular table. The last one is CDK4, which is a cyclin-dependent kinase, which is related to melanoma. Not really the highest yield, but I put it here for completeness sake. So these are cell cycle regulators.
Bro, freak that shit. Who the hell is gonna remember his chromosome 11-14 translocation? Oh my god, that's so dumb. Okay, he kind of skipped over. Holy shit. I'm gonna go back to the paragraph above where it talks about RAS. Okay, RAS is associated with growth factor receptors in an inactive GDP bound state. Okay. Receptor binding causes GDP to be replaced with GTP. Yep, activating RAS. Activated RAS sends growth signals to the nucleus. RAS inactivates itself by cleaving GTP to GDP. This is augmented by GTPase, right? Activating protein. Mutated RAS inhibits the activity of GTPase. Okay. Activating protein. This prolongs the activated state of RAS, resulting in increased growth signals. Okay. So that's RAS, which is signal transducer. Cell cycle regulators mediate progression through the cell cycle, e.g. cyclin and cyclin-dependent kinase. So cyclins and cyclin-dependent kinases, or CDKs, form a complex which phosphorylates proteins that drive the cell through the cell cycle. Okay. Cyclins and cyclin-dependent kinases. For example, the cyclin D CDK4 complex phosphorylates the retinoblastoma protein, which promotes progression through the G1S checkpoint. Oh, retinoblastoma. Okay. That was part 2. Part 3. Oh my god, I'm sleepy as fuck. Miss Days, you just chilling? You just chilling there, girl? You're so warm. So fluffy. Miss Days is so fluffy. It is so cold. Ugh. See, like, snow days are nice if you get to stay home and all, but, like, it's not nice when you have to study, because then, like, I just don't feel like studying. I just feel like, you know, taking a nap all day and snuggling up in my blankets and being all cold and chilling with the kitties. But no, I gotta fucking watch 50,000 Pathoma videos. And, like, bro, I just wanna sleep. It takes so much out of me, bro, each video. Okay, maybe these last 3 videos and then a break, and then we gotta go through chapter 6. Or maybe I'll take a break when I get through all of these. I don't know. We'll see my endurance.
We're talking about the fact that carcinogenic agents damage DNA, and when they damage DNA, there are some key regulatory systems that can be damaged. One key regulatory system that can be damaged are proto-oncogenes, and when they're mutated, they become oncogenes, and they can then result in the formation of a tumor. Another key regulatory system that can be damaged are tumor suppressor genes. And what do tumor suppressor genes do? They regulate cell growth. And so this is the discussion that we now want to have, and that is that what are tumor suppressor genes and how could they result in tumor formation? So the key idea here is that tumor suppressor genes, they decrease, i.e. suppress, the risk of tumor formation. And the 2 classic examples are P53 and retinoblastoma. So let's take a moment to discuss each of these. Now, what does P53 do? It regulates the cell cycle. In particular, it regulates the G1 to S phase. And the way I think about P53 is sort of like a traffic cop. Let's take a whiteboard. Let's imagine that the cell would like to go from the G1 to the S phase. So before it can go to from G1 to S phase, it's got to sort of go past P53. All right, now, when it walks past P53, P53 is like a traffic cop, and it basically says, all right, show me your DNA. And when the cell shows P53 its DNA, there's 2 possibilities. If P53 looks at the DNA of the cell and sees that the DNA is mutated, then P53 will actually blow a molecular whistle, and it'll call in DNA repair enzymes and repair the DNA mutations so that before the cell goes into S phase, the DNA is repaired. That's one possibility. Another possibility is that P53 looks at the DNA of the cell and says, there is no way this cell is going to go into S phase, because if this cell's got way too many mutations and we can't repair these mutations. So in that case, what would P53 do? It'll blow another molecular whistle, and it'll call in a molecule called BAX. And guess what BAX does? BAX goes in and it destroys BCL2. So BAX goes in and it destroys BCL2. And you know what BCL2 is? BCL2 is the molecule that stabilizes the mitochondrial membrane so that cytochrome C doesn't leak out. So if you knock out BCL2, cytochrome C will actually leak out of the mitochondria, and when cytochrome C leaks out of the mitochondria, it will activate the caspases, which will then create apoptosis of the cell. And so P53 has the ability to induce apoptosis when there's severe DNA mutation in a cell. And again, the idea is you want that cell to undergo apoptosis because it's got so many DNA mutations that there's a risk that it could produce a cancer. All right, so let's read together. What do I say here? P53 regulates the cell cycle, in particular, progression from the G1 to S phase. Now, again, what does P53 do? In response to DNA damage, P53 upregulates DNA repair enzymes. All right. However, if repair is not possible, P53 induces apoptosis. And I've already explained how apoptosis would occur. Now, it's important to note that both copies of P53 must be knocked out for tumor formation. And the way I think about this is it's sort of like an intersection, right? These are traffic cops, and if one traffic cop goes to lunch, then the other traffic cop can sort of man the intersection and there wouldn't really be any accidents. But if both traffic cops are not at the intersection becomes chaotic and there's an increased risk for accidents. And so the only way to develop tumors is to knock out both copies of P53. And that's called Knudson's 2-hit hypothesis. All right, that both copies of P53 must be knocked out for tumor formation is this notion that both copies must be knocked out is called Knudson's 2-hit hypothesis. Now, loss of P53 is seen in more than 50% of cancers. Usually, both copies of P53 are knocked out somatically. However, it is possible that a patient could inherit one bad copy of P53 from a parent, and that's called the Li-Fraumeni syndrome. And the Li-Fraumeni syndrome is associated with an increased risk for multiple types of carcinomas and sarcomas. So that's a little bit about P53. Another important tumor suppressor gene is retinoblastoma. And retinoblastoma also regulates progression from G1 to S phase. And the idea here is that, I'll just do this as a picture, when the cell wants to go from G1 to S phase, one of the key molecules that it needs in order to do that is called E2F. So E2F is necessary to go from G1 to S phase. And guess who holds on to E2F? So E2F is normally bound by retinoblastoma. And in order for E2F to be released, retinoblastoma must be phosphorylated. And when retinoblastoma is phosphorylated, it becomes very happy, and it releases E2F, and the release of E2F then allows the cell to go from G1 to S phase. So that is the sort of the normal function of retinoblastoma. Now, if there's a mutation in retinoblastoma, then E2F is free, and the free E2F will allow cells to easily go from the G1 to the S phase, and that will then result in the formation of a tumor. So this is why loss of retinoblastoma increases or results in the formation of tumor. So let's go back and read. So retinoblastoma regulates progression from G1 to the S phase. Retinoblastoma holds the E2F transcription factor, which is necessary for a transition to the S phase. Normally, E2F is released when retinoblastoma is phosphorylated. And who phosphorylates retinoblastoma? Cyclin D, CDK4 complex, which has the ability to phosphorylate proteins. If retinoblastoma is mutated, that results in constitutively free E2F. So for E2F will be free, and that allows for uncontrolled progression through the cell cycle. So that's the consequence of retinoblastoma mutation. Now again, same idea. Both copies of retinoblastoma must be knocked out for tumor formation, and that's called Knutson's two-hit hypothesis. If a patient has sporadic mutations resulting in both copies of retinoblastoma being knocked out, the patient will develop unilateral retinoblastoma. However, if the patient has germline mutation of retinoblastoma, the patient is more likely to develop bilateral retinoblastoma, and they also can develop osteosarcoma. Now, I think this requires a little bit of explanation, so I'm going to take a moment to back away and explain a principle here. Now let's take, so what is retinoblastoma? Retinoblastoma is a tumor that develops in the back of the eye. And I've included a picture here in your text, and here's the eyeball, and this is here the tumor sort of in the back of the eye arising from the retina, and that's a retinoblastoma. Now let's take for a moment a very simple example. I'm going to go to my whiteboard here and just explain something. Let's pretend that there is a patient, and we're going to draw a couple copies of retinoblastoma. So this is these are normal retinoblastoma genes on their chromosomes, and retinoblastoma, one copy is inherited from mom and one copy is inherited from dad, and so this is a child, and they've got two normal copies of retinoblastoma. Okay, now they've got, let's say in the back of the eye, they've got billions of cells sitting in the back of the eye, and each cell has two normal copies of retinoblastoma. Now, in order for a tumor to develop, one copy of retinoblastoma must be knocked out, right? And then in the exact same cell, that one cell in a billion, the second copy must also be knocked out. That's the only way, by knocking out both copies, that the tumor, retinoblastoma, is going to form. All right. So what's the probability that 1 in a billion cells would actually get hit? The exact same cell would get hit twice, and both copies would be knocked out. It's essentially 0. And that's why retinoblastoma is essentially almost never seen. It's a very, very rare tumor, and it's very unlikely that you would ever see it except on examinations. And so that's why I say here in your text that a sporadic mutation, the most those patients would ever develop is a unilateral retinoblastoma. Now let's take on the other extreme, and that is, let's say that the patient has, I don't know, retinoblastoma, okay, here and here. These are the father and the mother, and let's pretend that one of the parents has a bad gene. We'll put an X through it. Now what's going to happen is that the child is going to inherit one bad gene and one good gene, correct? Let's just make that as an example, that they happen to inherit one bad gene and one good gene. Now, in the back of the eye, every single cell, all the 1 billion cells, just as an example, in the back of the eye are actually going to contain or already begin with one bad gene because they inherited one bad gene. Now, what's the probability that an additional mutation could come in and hit the good gene? Sorry, this is a good gene here. What's the probability that that could happen? It's pretty likely. It wouldn't be unheard of. And so these patients, because the whole back of the eye is sort of like a field ready to be mutated, if any one of these cells gets hit, they're going to get a retinoblastoma. And similarly, if any one of the billions of cells in the back of the other eye get hit, they're going to get another retinoblastoma. And that's not too hard to occur because there's so many cells that could easily get mutated. And so that's why patients with a germline mutation, have an increased risk of usually get bilateral retinoblastoma. And what's also important for examinations, there's an increased risk of osteosarcoma. So that's something to be familiar with as well. Okay, and the third regulatory system are regulators of apoptosis. Now, remember that apoptosis needs to be regulated. And why does it need to be regulated? Because you want apoptosis to not occur in a normal cell. You don't want a normal cell to die, so you want to prevent apoptosis in a normal cell, but you want to promote apoptosis in mutated cells because you don't want cells whose DNA cannot be repaired. If there's DNA and it cannot be repaired, you want apoptosis to occur in that mutated cell. And so apoptosis is highly regulated. One of the important regulators of apoptosis is BCL2. Now, what does BCL2 do? I've told you this time and time again, but we'll repeat it one more time. BCL2 stabilizes the mitochondrial membrane so that cytochrome C cannot be released. If BCL2 gets disrupted, cytochrome C can leak out, which then activates caspases and subsequently results in apoptosis. So this is BCL2. Now, one of the high-yield principles to be familiar with regarding BCL2 is that BCL2 is overexpressed in follicular lymphoma. Okay, let's go back. Now, basically, the idea here is that in follicular lymphoma, you get something called the 14-18 translocation. Guess what sits on chromosome 14? Yep, immunoglobulin heavy chain. Okay, and guess what sits on chromosome 18? BCL2. You have to know that BCL2 sits on chromosome 18. Well, you would know that because of the 14-18 translocation. You know that BCL2 is involved in follicular lymphoma. So these are some things to be aware of. Now, this translocation, when BCL2 goes to the immunoglobulin heavy chain region, because we're dealing with B cells, this is occurring in B cells, then what's going to happen is BCL2 will be overexpressed. And then, because BCL2 is overexpressed, apoptosis will not occur because the mitochondrial membrane will be super stabilized because you've got super amounts of BCL2. Now, that's not really a problem because the vast majority of cells, and for the most part, B cells, you don't want them to apoptose anyway. However, there is one region in the body where you actually want a lot of apoptosis, and that is in the follicle. Now, why do you want that? Because remember what's happening in the follicle. In the follicle, the B cells are undergoing somatic hypermutation. What's somatic hypermutation? That's a random generation of mutations within the B cell so that you can increase the antigen, the diversity of the antibodies being produced by the B cell. So somatic hypermutation is a desired state, is a desired occurrence within the lymph node, but if the mutations fail, you want those cells to die. That's the mechanism by which cells die. So we could state it otherwise. When B cells are born in the bone marrow, and they're born as naive B cells, and then they go to college. And where do they go to college? They go to college in the lymph node. And in the lymph node, when they go to college, the way by which they fail in college is somatic. The test in college is somatic hypermutation. Are you able to produce a newly mutated immunoglobulin that might be able to react against antigen? And if you're not able to do that, then you have to fail. And the way by which the lymph node fails the B cell and removes it is apoptosis. So if the B cell is not able to undergo apoptosis in the follicle, it's gonna just pile up. And as the B cells pile up, that's going to produce a follicular lymphoma. Okay? And so one of the key features of follicular lymphoma is that the cells are not apoptosing, and the reason they're not apoptosing is because there is a markedly increased BCL2, and so the cells can't apoptose because the mitochondrial membrane is super stabilized. So that's BCL2 and its relationship to follicular lymphoma. A few other important features concerning tumor development. We've sort of concluded our discussion of the key regulatory systems, but there are a few other features to be familiar with. First of all, telomerase is a necessary enzyme for cell immortality. Now let's go back and remind ourselves. First of all, cells, when they divide, normally, each time a cell divides, its telomeres shorten. Okay? And telomeres are the very tenuous shortening of stop dividing. They need to keep dividing. It has upregulation. And that's an important general principle concerning cancer cells, that often telomerase is upregulated. Another important feature of cancer is that it requires angiogenesis. Tumor, if it's going to grow, is going to require blood. And so fibroblast growth factor, which is again an important angiogenic factor, despite the name fibroblast growth factor, and vascular endothelial growth factor are commonly produced by tumor cells to ensure tumor growth and survival. And then the final principle that I'd like to highlight is that tumor cells are mutated, correct? And so if they're mutated, they're going to be producing abnormal proteins. And if they're producing abnormal proteins, those abnormal proteins are going to be expressed on MHC class 1. And one way by which the human body can deal with tumors is when there's abnormal protein present in MHC class 1, the CD8 positive T cells come in and they can kill the tumor. And so CD8 positive T cells and MHC1 are highly important for something called immune surveillance of tumor cells, okay? So one of the ways by which tumors can avoid this immune surveillance is by downregulating MHC1. If MHC1 is downregulated, the abnormal proteins being produced by the tumor won't be expressed on the surface, and the CD8 positive T cells won't be able to come in and kill those tumor cells. So that's one way by which tumor cells can avoid immune surveillance. Another important association here, or derivative principle here, is that when patients have immunodeficiency, that's going to increase the risk for cancer because immune surveillance won't be functioning properly, and immune surveillance is an important mechanism for removal of tumor cells, or for protecting a host from the development of tumor. But I would say very important to remember here that CD8 positive T cells play an important role in immune surveillance by recognizing aberrant protein present on MHC class 1. And that really concludes, that's going to conclude this particular section. Relatively long section, but contains a lot of high yield. And so we spent a little bit of time here, but hopefully it'll pay off as we move through the course. So we'll go ahead and stop here, and the next section will be a discussion on how tumors can progress once they develop the necessary mutations to actually form a tumor.
Yippee! Tumor progression. 9 minutes.
Okay, tumor progression. Once you've understood the idea of carcinogenesis, and you understand that carcinogenesis is going to knock out key important regulatory elements, then the next notion is that as a tumor cell grows and begins to produce additional daughter cells, it will pick up additional mutations. And those additional mutations will allow for tumor progression. And so eventually what will happen in the case of cancer is that accumulation of mutations will result in invasion and spread. And remember that the hallmark of cancer, of malignant neoplasia, is that it locally invades, and the defining feature of malignant...
I hear Miss Luna's meowing outside. Miss Luna! No, but if I let her inside, she's gonna walk all over my keyboard, bro. I'm sorry, Miss Luna.
Neoplasia, or cancer, is that it will spread to distant sites, which is also called metastasis. Now, in order for this spread to occur, there are a few characteristic changes that have to arise within the tumor to promote such spread. And so what I'd like to do is walk you through those. The first is downregulation of E-cadherin. Normally, when you look at epithelial cells, these are epithelial cells, you're well aware from histology that epithelial cells sit on a basement membrane, and that these epithelial cells are attached to each other by various molecules, one subgroup of which is called the cadherins. And within cadherin, a particular molecule is E-cadherin. Now, cadherins, they keep the cells attached to one another. And if tumor is going to form, for example, from this cell, what needs to happen in order for it to be able to spread locally and then to metastasize is this tumor cell needs to be able to dissociate from its neighbors. One way by which it dissociates from its neighbors is via a downregulation of E-cadherin. And so one characteristic that I've listed here in your text is downregulation of E-cadherin. Now, once E-cadherin is downregulated, then this cell will attach to the laminin, which is present which is present in association with the basement membrane. Go back and recall from normal histology that the basement membrane is basically composed of two key molecules. The first is collagen 4. Collagen 4 makes up the vast majority of the basement membrane, and then the basement membrane also has laminin associated with it. And so the cells, once they dissociate from the neighboring cells, will actually attach to the laminin within the basement membrane. Now, once they attach to the laminin within the basement membrane, the next step would be to destroy the basement membrane. And tumor cells can eventually develop the ability to produce collagenase, in particular collagenase that would destroy collagen type 4. Binding to the laminin and destruction of the basement membrane will then allow the cell to eventually come out here into the extracellular matrix. Now, once the cell is within the extracellular matrix, it will attach itself to fibronectin. It'll attach itself to fibronectin within the extracellular matrix, and then it can spread locally. Eventually, it'll gain access to either the blood vessel, or it may gain access to lymphatics. And when it gains access to lymphatics, it'll spread to lymph node. And if it gains access to blood vessel, it will spread to distant sites. And so this is sort of a little bit of a paradigm. Step number 1, downregulation of E-cadherin. Step number 2, the cells then attach to laminin. Step number 3, they destroy the basement membrane using collagenase type 4. Step number 4, they attach to fibronectin in the extracellular matrix and begin to spread locally. And then step number 5 would be to enter into the vascular or lymphatic space. And if we go back to the slide, each of these steps is listed here in sequence, and you can review this within your text as well. I've already basically explained this slide to you. Recall that one of the hallmarks or the key hallmark of a malignant tumor, i.e. cancer, is that it will spread to distant sites. And so it's important to know that carcinomas, they tend to spread via the lymphatics. So the place where you expect to see carcinoma would be the regional draining lymph nodes. I'll just give you one example. Take, for example, breast cancer. So when a patient develops breast cancer, one of the common sites or one of the initial sites of spread is into the lymphatics and then through the lymphatics into the axillary lymph nodes. And recall that the axillary lymph nodes are the lymph nodes that drain the breast. And so one important principle to know about carcinoma, about cancer, is that carcinomas spread via lymphatics to regional nodes. General principle. Carcinoma spread via lymphatics to regional lymph nodes. To highlight this, I've placed a picture in your text, and you can clearly see what this picture basically is that of a lymph node. So I'm highlighting here the capsule of the lymph node. This area here represents the normal lymph node with these small dark blue cells. And then clearly we can see that there is some tumor here, which is replacing the lymph node. And notice that the tumor has a bunch of white spaces within it, and these are glands, and is an adenocarcinoma. And so I've only placed this here to remind you of the general principle that carcinomas tend to spread via the lymphatics into regional lymph nodes. Cancer can also spread hematogenously. And hematogenous spread is characteristic of sarcomas. Recall from the beginning of this lecture that sarcomas are a malignancy of mesenchymal tissue. So, for example, an osteosarcoma is a malignant bone tumor. A chondrosarcoma is a malignant cartilage tumor. A liposarcoma is a malignant tumor of adipose tissue. So mesenchymal or connective tissues, when they're malignant, we call them sarcomas. And sarcomas tend to spread through the blood. They go into the blood vessels, and then they spread to distant sites. So that's a general principle. So principle A of this discussion, principle A, is that carcinomas go into the lymphatics and spread to the regional lymph nodes. And principle B would be that sarcomas go into the blood, and characteristic site of spread would be the lungs. Now, there are some exceptions, and so the exceptions become high yield because they make for nice test material. There are a subset of carcinomas that like to spread into the blood. So again, they're breaking the rule. And so it's important to be familiar with these exceptions because, again, it makes for nice test material. So one exception is renal cell carcinoma. And renal cell carcinoma, it's one of the characteristics of renal cell carcinoma is that it likes to invade into the renal vein. And when it invades into the renal vein, it can present with distant metastases. And it's not uncommon for a patient with renal cell carcinoma to present with distant metastases. Another carcinoma that likes to go into, that likes to spread hematogenously is hepatocellular carcinoma. This likes to invade the hepatic vein and then can spread to distant sites. A third carcinoma that likes to spread hematogenously is follicular carcinoma of the thyroid. And the fourth is choriocarcinoma. And choriocarcinoma is really easy to remember because what is choriocarcinoma? Choriocarcinoma is a malignancy of placental tissue, in particular, the cells that line the villi of the placenta. And those cells are called trophoblasts. And so choriocarcinoma is a malignancy of trophoblasts. And guess what trophoblasts are designed to do by their nature? They're designed to find a blood vessel and invade into blood vessel. In fact, that's the job of the placenta. And so choriocarcinoma, I don't think it's too hard to remember that it's going to go into the blood and it's going to spread hematogenously because that's sort of what those cells are programmed to do to begin with. Now, a third way by which cancer can spread is by seeding body cavities, and that's characteristic of ovarian carcinoma. Ovarian carcinoma has the propensity to seed body cavities. It often involves the omentum of the abdomen, and so a classic picture that can arise is something like this, where we can clearly see that we're in the abdomen. This is a loop of bowel, and this is cancer that has completely replaced the omentum. This, were we to actually cut through this would be very thick, and when you cut through this with a knife, it sort of has the consistency of cake. And so another term to describe this phenomena is called omental caking. And that is an important term to be familiar with, and I've placed it in your text as well. So that concludes this section on tumor progression.
Yeah, that's not what the omentum looks like, bro. All right. Clinical characteristics, 20 minutes. Oh, my attention span is... Okay, but this section doesn't look to be too long, so...
The final section of this chapter deals with the clinical characteristics of neoplasia. And the idea here is that once you go through the sequence of carcinogenesis and tumor progression, eventually the patients will present with certain important clinical characteristics. And so that's what we want to discuss here. Now, we're not going to discuss specific characteristics for each individual tumor, but we're going to discuss some general concepts that you need to have concerning neoplasia and how it might present clinically. So obviously, we know that neoplasia can be divided into benign and malignant. So there are benign tumors and there are malignant tumors. Generally speaking, benign tumors are going to be slow growing. The patient may give a history of having a mass that has grown slowly over many years, for example. Another characteristic is that the tumor will be well circumscribed, and that would be where you would examine the tumor clinically and it's clearly distinct and separate from the adjacent tissue in which it's growing. So, for example, a patient has a breast mass, and the breast mass is clearly distinct and separate from the remainder of the breast tissue. And so that's basically what we mean by distinct here. And finally, it's mobile. And what does mobile mean? It means that if you take the mass and try to move it around, for example, if it was a breast mass, and you try to move it around, it's easy to move the mass around. And what does that tell you? That tells you that the mass is not invading into local tissues, is not attaching itself, for example, to the chest wall in the case of the breast. And so these are some classic clinical features that we would expect in benign tumors. In contrast, malignant tumors would have the following characteristics. Malignant tumors are usually rapidly growing. The patient usually gives a history of a tumor that's grown within a year or grown sometimes within months. They're poorly circumscribed. You try to sort of get your hand around the tumor, for example, if it's a breast cancer, and you can't really separate it from the adjacent surrounding normal breast tissue. It infiltrates into local tissues, and it's fixed to surrounding structures. It's not mobile, but instead it's attached, for example, to the chest wall in the case of breast cancer. And so these are some classic clinical features concerning benign and malignant tumors. It should be noted, however, that sometimes a benign tumor can have malignant characteristics, and sometimes a malignant tumor can have benign characteristics. And so these clinical features are simply screening tests. The only way to make an absolute diagnosis of cancer is biopsy or excision. Otherwise stated, it's the pathologist who makes the final determination of cancer. The only way, again, to make an absolute certain diagnosis of cancer is that the tissue must be biopsied, or it must be excised. And so that's an important principle to bear in mind, and that'll come into play later when we have some discussions about screening tests as well. Now, what are some of the histologic features of cancer? If cancer is going to be determined on biopsy by looking at the cells under the microscope and clearly calling them malignant, then we need to understand the histologic features of cancer as well. Now, generally, when we think about benign tumors, they look very similar to the tissue in which they're growing. For example, the benign tumors usually have an organized growth. The nuclei will be uniform. The nuclear to cytoplasmic ratio will be low. What does that mean? It means there'll be a lot of cytoplasm in the cell and maybe a small nucleus. That gives you a low nuclear to cytoplasmic ratio. There'll be minimal mitotic activity, a lack of invasion, and this tumor will have no metastatic potential, meaning that the tumor will not have the ability to spread outside of that particular organ in that patient or in any other patient. All right, and so that's how we understand no metastatic potential. And again, this word potential is important because what we do is when a biopsy is performed and I see a certain pattern and I call that, let's say, for example, I call that a benign tumor, like in the breast, I call that a fibroadenoma. I know that fibroadenomas don't metastasize historically in all the patients that have had fibroadenoma, and that's what makes it benign. And so it has no metastatic potential in the patient who's now developed a fibroadenoma as well. So those are some histologic features of benign tumors. The histologic features of malignant tumors are as follows. It's usually poorly differentiated, and I say usually because it doesn't always have to be. It will have disorganized growth where it doesn't really look like the tissue in which it's growing. There'll be nuclear pleomorphism. Some of the nuclei will be big, and some of the nuclei will be small. There'll be hyperchromasia. The nuclei will be very dark blue. There'll be a high nuclear to cytoplasmic ratio. So if this is the cell, most of the cell will be comprised of nucleus. And what does that indicate? That indicates that the cell is very active and that the nucleus is completely open and is rapidly transcribing genes, etc. There'll be a high mitotic activity, indicating that the cells are rapidly dividing, and there'll be invasion into local structures. And so these are some of the histologic hallmarks that help us to classify a tumor as benign or malignant. Now, here's an example that I've placed in your text to highlight some of these principles, and we're basically comparing and contrasting. So this picture on the left This is an example of a follicular adenoma of the thyroid. Now, a follicular adenoma of the thyroid is a benign tumor, and when you look at the tumor, it shows many of the characteristics that we would expect to see in a benign tumor. For example, here we can clearly see that these cells, by the way, the entire picture here, this entire picture that I'm squaring away represents the tumor. So here we can clearly see that the cells are organizing themselves in little round spaces, as you would expect to see within the thyroid. Remember that the thyroid makes follicles, and the follicles are lined by follicular cells. And often in the center of the follicle, you see colloid, and you can clearly see some pink colloid in the center of these round nests of cells. In addition, you can see that the nuclei are sort of regular. All the cells sort of have round, similar-looking nuclei. You don't really see any mitotic activity. The cells don't have a very high N-to-C ratio. In fact, when you look at the nuclear to cytoplasmic ratio, you can clearly see that if this is a cell here, the nucleus is small and there's a lot of cytoplasm above it. So these are all features that we would expect to see in a benign tumor. And indeed, on the left, we have this benign thyroid tumor, i.e. a follicular adenoma. Now, on the right, what I've exhibited here is something called anaplastic carcinoma of the thyroid. Now, when you look at this tumor, you can tell that clearly it's not making any nice round spaces with colloid in the middle. You can see that the cells are larger than the cells on the left. You can see that there's mitotic activity. This is a mitotic figure here. You can see that the nuclei are big, and you can see that they take up most of the cell. And so all of these are features of histologic features of a malignant tumor. Now, it's important to note, however, that again, benign tumors can sometimes have malignant features, and malignant tumors can sometimes have benign features. So what is the absolute distinguishing feature between benign and malignant? And this is what examiners like you to know. The absolute distinguishing feature between benign and malignant is metastatic potential. Benign tumors do not have metastatic potential. Malignant tumors have metastatic potential. So this is a very important take-home point because it's the absolute distinction between benign and malignant tumors. One important clinically useful test in this context of neoplasia is immunohistochemistry. And the way we use immunohistochemistry depends on the circumstance that we're challenged with, but let me just give you a couple simple examples. Let's pretend that I have a very poorly differentiated cancer. What does poorly differentiated mean? It looks nothing like any normal tissue. So the patient has a mass, they do a biopsy, and when I get the biopsy, I see that the cells are poorly differentiated. They don't look like anything that we're used to seeing. And so when I see those cells, in the back of my mind, I begin to think, is this carcinoma, meaning is it epithelial? Is it lymphoma, i.e. are the cells lymphocytes? Is it sarcoma, i.e. are the cells derived from mesenchyme? Are they some sort of connective tissue cell? Or is it melanoma, for example? And I start with a very broad differential diagnosis because these are all my common subtypes of cancer. Now, I can look at the cells and try to use morphology to help me to determine what cell type I'm dealing with, but another useful technique to determine the type of cell is called immunohistochemistry. The idea here is that we take an antibody against a particular target, and we label that antibody with a brown stain, and then we place that antibody on the cells. And if the antibody binds the cells, then it helps us to identify particular proteins that might help us to subclassify the cell type. And it's important to be familiar with this because, of course, it's useful clinically, and also examiners like to go after it because it really draws in some of the basic principles of histology. So this is a great way to sort of test your histology. Now, let me remind you that cells have a cytoskeleton, and the cytoskeleton contains filaments, and one of those filaments is the intermediate filaments. One subtype of filament of the cytoskeleton is the intermediate filament. Now, it so happens that the intermediate filaments, they vary depending on the type of cell that you're dealing with. So, for example, if we're dealing with an epithelial cell, or we can say that all epithelial cells, the intermediate filament that makes them up is keratin. So let's say that I have a tumor and I can't recognize whether the tumor cells are epithelial or something else, and I wanted to prove that they're epithelial. Well, I could do an immunohistochemical stain for keratin, and if the cells are keratin positive, that would indicate that I'm dealing with a carcinoma, because remember, carcinoma is the name that we use for malignant epithelial tumors. All right, let's play it another way. Let's pretend that I've got this tumor, and I do an immunohistochemical stain, and I see that the cells are positive for vimentin. Well, vimentin is an intermediate filament that is present within mesenchymal cells, i.e. connective tissue cells. And so if I have vimentin positivity, one of the things that I could deduce is that I'm dealing with a sarcoma, because I've got a malignant tumor. Obviously, I can't recognize it. The cells are poorly differentiated, and it's vimentin positive. Playing along the same lines, let's say that the cells are Desmond positive. That would indicate that I'm dealing with muscle cells. If they're GFAP positive, that would indicate that I'm dealing with neuroglial cells. And if they're neurofilament positive, that would indicate that I'm dealing with neurons. So these intermediate filaments are very high yield because it goes back to histology and because we use these clinically. It's not uncommon for us to order a battery of immunohistochemical stains when we're trying to subclassify tumor. So you do need to be familiar with this. Now, obviously, I'm painting very broad strokes and highlighting some general principles. There are some exceptions to these rules, but I think for your purposes, this is what you need to understand. Another way that we could play the game is that, let's say we have a tumor, and we know that it's a carcinoma, it's making glands, and we're concerned about whether it might be from the prostate or it might be from another organ. Well, we could do an immunohistochemical stain for PSA, and if the cells are PSA positive, that would suggest that we're dealing with a prostate cancer. Similarly, with breast, if a woman has a metastatic cancer in the lung, and I'm worried about where that tumor came from, one potential way of determining that would be to do an estrogen receptor stain. And if the estrogen receptor is expressed in those cells, it's possible that I'm dealing with a breast cancer because estrogen receptor is commonly seen in breast carcinoma. Thyroglobulin would help me to identify a thyroid cancer. chromogranin would help me to identify neuroendocrine carcinomas. And I would say from my personal experience that chromogranin is a relatively high yield stain to be familiar with. It's commonly tested by examiners. The most well-differentiated and sort of best type of neuroendocrine cancer that you can get is called a carcinoid tumor, and the worst and most poorly differentiated neuroendocrine tumor that can develop is a small cell carcinoma. And so this is sort of a spectrum of tumors that arise from neuroendocrine cells. It is important to understand that both small cell carcinoma and carcinoid tumors are sort of derived from the same cell type, i.e. neuroendocrine cells, and it is very high yield to know that chromogranin is expressed in neuroendocrine cells. And then finally, the last of the stains I've listed here is S100, and S100 is useful for many things, but it's particularly useful to mark melanoma. So, the way that examiners like to play the game with immunohistochemical stains is that they might say to you that there's a tumor and a biopsy is performed and the pathologist sends you a report saying that he sees or she sees keratin positive cells. So they would then ask you, what type of tumor are you dealing with? And the answers could, the choices could be A, carcinoma, B, melanoma, C, lymphoma, D, sarcoma. And obviously because it's keratin positive, that would indicate epithelium, which would then indicate that you have a carcinoma. So I hope that I've made that clear because it is a relatively high yield topic. Here's a picture of an immunohistochemical stain just to let you know what one looks like. Basically, this brown staining indicates that the cells are reacting with the particular antibody that we've introduced in this test. Now, another way by which we can classify tumors and follow the treatment and response of tumors are serum tumor markers. What are serum tumor markers? These are proteins that are released by the tumor. They are released, obviously, into the serum. Now, these serum tumor markers can be useful in three circumstances. Some serum tumor markers are useful as a screening test. For example, PSA is a protein that's released by prostate cancer, and it gets released into the blood, and we can then detect it in the blood, and so it's useful as a screening test. That would be one use of a serum tumor marker. Another use of serum tumor markers is to monitor response to treatment. For example, patient has a prostate cancer, the PSA is 15. The surgeon goes in and removes the prostate cancer and removes the prostate along with the cancer. And after removing the prostate along with the cancer, we would expect the PSA to drop to near zero. And so this would be a way by which we would monitor response to treatment. And then let's say that the patient comes back in, 2 years later, and when they come back in 2 years later, they have bone pain. Well, if we did a PSA and the PSA was now high, that would help to prove that perhaps the patient has a recurrence. And so these are some of the uses for serum tumor markers. I want to remind you that when it's used for screening, elevated serum levels still require a tissue biopsy for diagnosis. I think I've already hammered home this point. You cannot make a diagnosis of cancer without a tissue biopsy. And so even if a patient has a super high PSA, let's say, some crazy number like 300-400, that still would require a tissue biopsy before a diagnosis of carcinoma can be made. And so, for example, if I asked you a question where I said, patient comes in for screening and a PSA is performed and the PSA is markedly elevated, what's the next step? A, surgery, B, biopsy, C, D, E, etc. The answer would be that you still need to biopsy the site and prove that it is tumor that is indeed causing that elevated PSA. And that's because other things can elevate the PSA as well, not only cancer. Now, once a patient has a cancer and we've made the diagnosis of cancer, the next thing that the pathologist does, which is important for prognosis, is to grade the cancer. And what does grading of cancer involve? It involves asking the question, does the tumor look like the tissue in which it's growing? So the more the tumor looks like the parent tissue in which it's growing, the better differentiated it would be. And so if it resembles the parent tissue, as I've stated here, it's well differentiated. And if it does not resemble the parent tissue, we call that poorly differentiated. How do we determine differentiation? Well, we look at the architecture of the cells and ask, does the architecture resemble the normal architecture of that tissue? And then we also look at the nuclear features, like, for example, the mitotic activity. Again, as I've mentioned, grading is important for determining prognosis. The better differentiated a tumor is, or a cancer is, the better the prognosis. So a well-differentiated cancer has a good prognosis. A poorly differentiated cancer has a poor prognosis. Another important feature of cancer that we need to be familiar with on a clinical level is staging. And staging basically asks the question, how far has the cancer grown? So what's its size or depth of invasion? And how far has the cancer spread? So it's based on two things, size and spread of the cancer. Now, this is the key prognostic factor. It is the number one prognostic factor. It is more important than grade. And the final staging is really determined after resection of the tumor. So clinically, we can stage a patient. We can try to determine what we think the clinical staging would be based on our clinical exam. However, the true final staging is based on resection of the tumor. When the tumor is removed and the pathologist analyzes the tissue, they then provide a final pathologic staging for the cancer. Now, what system do we use for staging? It's called the TNM system. It looks at three key factors. It looks at the tumor and asks the question, how big is the tumor or how deep has the tumor invaded? Generally speaking, tumor size is important in solid organs, and generally speaking, tumor depth is important in organs that are tubular. So, for example, the bowel, its depth of invasion is important in the bowel, whereas in the breast, size is important because it's a more solid organ. So that's the T part of the TNM staging. The N in the TNM refers to the spread to regional lymph nodes. This is the second most important prognostic factor. And the M refers to distant metastasis, i.e. away from the regional lymph nodes. And this is the single most important prognostic factor. Metastasis is the single most important prognostic factor in the TNM staging system. And you do need to be aware of that as well. And so that really closes off our discussion of neoplasia. Again, we've just laid out some very general principles. Much of this is going to be repeated as we cover systems, but it's nice to have a little bit of a framework as we move forward, and that was the goal of this lecture.
Oh my god. I'm sleepy as hell, bro. Okay. Then we just have chapter 6. And then what I'll probably do is go through flashcards. Or at least try to make some for... I'm so fucking behind. How long is this shit, bro? Oh dear god. Oh. Okay. Wait. Okay, that's for tomorrow. Fucking hell. Okay, that's not bad. You could do that. I was thinking of like going through the boot camp videos instead, but like they're kind of long, so it's just like, well, I guess not too long. Maybe if I didn't procrastinate, I would have had time. But anyway, I do like their slides. But yeah, Pathoma is just like the quickest way to get through all the content. So we've watched up to here. Now we gotta do these 4. Oh my god, there's so much sketchy. You know, I don't know how much I like sketchy. It's just like, I don't know, it just, well, I guess it helps. But ay ay ay. Alright, I think we are gonna take a little break to eat. Maybe nap, maybe not. I'm like really sleepy. And then come back and finish the rest. Yep, that's the plan.